Good morning, friends. Welcome to this session on individualizing blood pressure in various clinical conditions. Great to see a packed hall after the morning plenary session. I'm Sheila Mayatra, Professor of Intensive Care, working at the Tata Memorial Hospital in Mumbai, India. And along with me to co-moderate the session is Professor Jean-Louis Taboul. Sorry, too much of Professor Vincent today. From Paris-Saclay University in Paris, France. Over to you.
It's not a good start. Good morning, everyone. So we'll start right now by the first presentation about cardiogenic shock, how to individualize blood pressure in cardiogenic shock by Alexander Vlaar from Academic Medical Center, Amsterdam.
Thank you very much, chairs, for this leading this setting. I think of a very important session, individualizing blood pressures in several areas, and I'm happy to start with cardiogenic shock. I've got a few conflicts of interest I have to show. And I just want to go to a few items discussing individualizing blood pressures in cardiogenic shock. I think we need to have some historic perspective. Where are we coming from? Which interventions have been done in cardiogenic shock? The current guidelines, the downside of current practice, and future research. So I think the importance of realizing cardiogenic shock is that there is a factor for the heart. So here you see the heart with all the vasculature, which is immense, which is not doing well in cardiogenic shock, resulting in hypoperfusion. And so what I think is very important that we understand the root cause of the cardiogenic shock and see what we can improve. And this is, I think, some beautiful research history in cardiogenic shock which has been performed. So the first big question, I mean, if you think about it, it is just 25 years ago. In a way, it's long, but on the other hand, it's short in medicine, is whether we should early revascularize those patients, because in the beginning was just let them go through cardiogenic shock. If they stabilize, then we will start to do something about the root cause. So this study of Hochmann, they did a trial in early intervention revascularization. It could be CABG or percutaneous intervention versus waiting till recovering of cardiogenic shock and then do the intervention. Well, they showed it was beneficial to do this immediate revascularization, which is standard of care. Then we got Daniel de Bakker. He's also one of the speakers. The big question, should we give dopamine versus noradrenaline in a broad setting of shock, in which the subset of cardiogenic shock was suggested for better outcome of with noradrenaline. Then we used already a lot of intra-aortic balloon pumps with the early revascularization. It was about 90% of patients having this kind of devices. And then it was questioned, because it was just based on registry data, is this really a good approach? The trial showed no improved outcome with using intra-aortic balloon pumps as standards of care in cardiogenic shock. Then the other question had, because we knew early revascularization was good, but there are more vessels which have some issues. So should we just do the culprit lesion or a multi-vessel approach straight away? And then it turned out in the Thiele trial that the culprit lesion only was the best. Then the other question came, should we use only noradrenaline or should we use epinephrine, which is really more driving the contraction of the heart? And it turned out it was stopped early because of the downside of epinephrine. So noradrenaline was better in that setting. And then recently we had, of course, the ECLS study, standard study in cardiogenic shock versus control, and it turned unfortunately negative. And then, of course, we have several Impella studies from our side. Of course, we also did some Impella studies, and maybe it's not representative just to show one positive study, because there are many negative, but in a very small subset of cardiogenic shock, we know the study, there might be a better outcome with Impella support. So it looks very nice, everything what we have done, early revascularization, compared with all the medication we have, noradrenaline seems to be better, culprit lesion, and maybe in a subset we can do some unloading device. But if we now look at, because we are targeting the blood pressure, noradrenaline, is this really the way to go? I don't know. So we have to look, where are we coming from? If we look at the target map, we are taking it from sepsis studies, in which we think at a certain threshold of 65 we get issues with organ perfusion. But if you look at the bottom, distributive shock is totally different, something else than cardiogenic shock. And we're just applying the same map. And is that true? Because yes, of course, we see here, if the map goes down, it's associated with higher mortality. But is normalization of the map then the answer for this relation? And we know from history in ICU medicine that we see low numbers, we start correcting them, and then we think everything will be better. If we have low hemoglobin, we correct it with higher hemoglobin, and then the patient will walk again. No, that's not true. And the same big question, I think, we still have not answered it, is if we are adjusting this map in cardiogenic shock, is it really improving outcome? If we look at the guidelines, either they make no recommendation, or they say, we don't have anything better, we look at different patient population, we extrapolate it, and we will apply it. So maybe the MAP 65 is not good. We should go higher because we have cardiogenic shock, we need perfusion, we have a brain to protect, and I will not talk too much about the brain because it will be later on, but it has been investigated in patients with outflow cardiac arrest whether a higher blood pressure would be better. And we could discuss, of course, about the definition of cardiogenic shock in those patient populations. The starting lactate was 5 to 6 at baseline, so they were fulfilling the definitions. Even going higher to 80 or 90 MAPs is not improving outcome. So what is the downside of current practice? So first, do not harm. And what we do know is by giving noradrenaline, we have an increased potential in lactate. If we look at the vessels, we want to give blood, of course, and we're thinking about the perfusion pressure. But we also need to realize that the downside of giving those drugs is squeezing the vessels, which need to be open to the organs in the end to have perfusion. So we do know that noradrenaline increases afterload, decreases cardiac output by an increased end systole volume, increased workload, increased myocardial oxygen needs, and maybe even unloading or a lower afterload is better in this patient population. And from physiology reasoning, we can reason the same direction that we actually should go lower in this setting. But it's tricky, and because we like the normal numbers, we think about brain perfusion, but going higher is not giving the outcome we need. Yes. So there are some signals of ultrasound studies with perfusion of myocardial that increasing the norepinephrine dose is reducing the myocardial blood flow. So there is a downside of this treatment. And even going further down the road, this is in human volunteers, which are being exposed with LPS, and on the orange on the left side is noradrenaline, the right is vasopressin, and you see that the noradrenaline is giving an immune paralysis with an increase in IL-10 and a decrease in TNF. So it dysregulates immune host response, compromises host defense. So maybe in that way, we are really giving also a negative effect with our noradrenaline on our perfusion, on our organ microperfusion, as well as on our immune system. So it means we need further research. And I think the time is right now, and it is there, to challenge whether this map of 65 for all the patients is good, or we should individualize and really look whether this map and this blood pressure target in cardiogenic shock patient is good. So this is why we are doing right now the NORSHOCK trial in Europe. It's a randomized controlled trial in which we randomize for a lower map compared to the standard map of 65, with actually two questions. Is this lower map better by having a lower afterload, improving the circulation, but also by reducing the noradrenaline exposure? So inclusion criteria are acute myocardial infarction, early revascularization, and cardiogenic shock. Exclusion, a long resuscitation time, because we think in a way the outcome of those patients is already determined by the outflow cardiac arrest and the low perfusion time. And actually, if they have return of spontaneous circulation, we are actually doing harm with those higher blood pressures. So no mechanical cardiac support. We randomized in the cath lab with an index of 55 or 65. We even would love to go lower, but the IAB at this time found it too scary to go lower than this. But I think if we finish this trial, we hope to go further down. And then in the ICU, we monitor, we sample, and the primary endpoint is 30-day mortality composite with renal replacement therapy. And we have a follow-up. Of course, we have a bailout, because if this lactate is high, people want to start doing things. And we had the presentation of Jan Bakker also showing that this lactate is just a number. And we really should think, what is the cause of it? So first of all, it's really weight. Accept this lactate, then look at your hemodynamic profile, whether you should improve something there. And then if it keeps increasing, then at a certain time, you can increase the MAP. And so far, the Data Safety Monitoring Board is giving positive feedback. This is the team. We have almost the whole of the Netherlands. We have a large part of Europe enrolling. We are now targeting 776 patients, and we are now almost at 1/3 of the enrollment. So I hope soon we can show you the data. If you want to participate, send me an email. And getting to the conclusions, current blood pressure targets in cardiogenic shock are not based on cardiogenic shock patient population. I think it's very important for everybody to realize higher blood pressures seem not to improve outcome in this patient population. Although low MAP is associated with poor outcome, it does not mean that increasing the MAP will improve outcome. And the randomized trials are underway whether a lower MAP and reducing noradrenaline exposure is better. Thank you very much.
Thank you very much for an excellent presentation. The floor is now open. We can take 1 or 2 quick questions. Yes. Please introduce yourself. Can we have the mics here?
Hi, thanks. Nick Barnett, London. Yeah, I just wanted to know in the trial, how would you be able to tell the difference between your intervention, whether it was the low MAP or the noradrenaline exposure, let's say, that was causing some improvement or not? And secondly, mean arterial pressure is, as we know, very much driven by diastolic pressure. And, you know, some people just land with a mean arterial pressure of 60, let's say, for reasons that we don't fully understand, but they have higher diastolics than others. We don't really know why. How are you going to be able to decide, you know, that they fit into a 55 or a 65? Are you going to actually physically lower their maps so that they reach a target of 55? Thank you.
Yeah, so the first question, how are we going to distinguish if there is an outcome, whether it's actually the lower MAP or the noradrenaline dose? It's a very difficult one to separate, because, I mean, starting to give nitroglycerin to lower the MAP, I mean, it is, I think, very difficult approach. Could be another trial to have your question specifically answered, but it's more a pragmatic trial in which we just combine both of them, having a lower MAP and having lower noradrenaline. The second question, indeed, there might be still individualization in which the MAP is not the perfect endpoint. We did surveys on what physicians are using in the world. 80% is using MAP as the way they are approaching the patient. So yes, I'm totally right that if we really would look deeper individualizing your approach, it could be better. On the other hand, we have to realize that the pragmatic approach in the world at this moment is this approach. I hope it answers.
Yes.
Hi, Kieran Donnelly in Birmingham, UK. Why are women under 45 in your exclusion criteria?
It's from an IAB perspective, and it has to do with pregnancy. And
yeah. Thank you.
Yeah. So in a way, I would love that we start stopping that and having an equal spread in all the trials, but it's still something which is, I think, for a different session to discuss.
Alexander, I have a question, a comment, a question, I don't know how to say. I'm a little bit surprised by the design of your study. I would have expected a different design, 65 versus higher levels, because cardiogenic shock are often characterized by high CVP, which is a downstream pressure for organ perfusion. So if CVP is high, how do you deal with this? 55 seems to me very, very, very low for the map. In this case of high CVP, for example, 15 or more.
Yeah, again, it is I understand your reasoning, and I agree with it. But on the other hand, we have this pragmatic setting where we have to take it, I think, the way we are taking it right now. So yes, and in the end, if the patient would deteriorate, we have our flowchart where you can change your approach, and you can go away from your MAP 55. You can optimize from a different perspective. But I think, and this is our observation, and this is, I think, also what we see now with our data safety, at least as a positive signal, that after so many enrollments, we are still having a green light for continuing the trial, that there is a huge percentage of patients we define as cardiogenic shock. We're giving a lot of vasopressors while actually it is not improving the patient.
I'm sure there are many more questions, but in the interest of time, we'll proceed. Our next speaker is Professor Daniel De Becker from Schirek Hospitals in Belgium. He's a doyen in the field of hemodynamics and sepsis, and he's going to be talking to us about individualizing MAP in septic shock.
So good morning. So indeed, we may discuss what are the support for trying to reach a given blood pressure, and we have a lot of data, indeed observational, like this one, showing that yes, below somewhere 65, you have indeed an increase in the mortality that is really spiking quite high, and of course most of the patients are in this also 65 area. Something very important also to take into account, and perhaps even more in sepsis than for the heart, is that yes, the heart may be somewhat preserved for decreasing blood pressure more than other organs, and especially if you think at the kidney, the gut, the liver, these are much more sensitive to decrease in blood pressure. And so we may also have perhaps to individualize based on that aspect. And if you look at this, also indeed, the incidence of acute kidney injury is also peaking high when the blood pressure is decreased. Something already alluded by Jean-Louis Teboul, our chairman today, is that indeed we have also to take into account the perfusion pressure, including then the back pressure of the organ, including the CVP, and of course for the respirologist, the PEEP that you apply to your patient, because when you have PEEP of 20, this has also a major impact on the perfusion of the organ outside the thorax. So what should we reach? 65, lower, higher? It depends, of course. If we look at the trials, we have several trials like this, comparing a higher and lower blood pressure target. And indeed, there is no major difference in outcome in that trial. And you have also here another trial. Be aware. This is very important. They begin by, and you will see this in the clinicaltrials.gov, that indeed it was permissive hypotension. And when you look at the title, it is reduced exposure to vasopressors. And I will explain you why it was not a trial on permissive hypotension. And so indeed here, what they were targeting is usual care versus C65, and there was no difference in outcome also in that trial. Why is it not permissive hypotension? Look at the targets of the two trials. If you look at what was effectively achieved, it's also quite interesting because indeed, so these are exactly the same scale for the two trials. You can see that indeed in the French ASFAR trial, it was not really 65, 70 that was tested, but it was more 70, 75 versus 80, 85 indeed. For the Canadian trial, this was indeed the usual care. That was indeed also 70-75, but also the so-called 60-65 permissive hypertension was in fact 65-70 because very few patients were indeed below the 65 there. So it was not really permissive hypertension, it was actual goals versus actual higher goals in practice. So anyway, what were the conclusions at the end? Well, no difference. We need really to be cautious there because indeed we just need to go one step further, which is individualizing the MAP targets according to the patient we are treating, including indices of organ perfusion, and not just go for a very specific limit. When I'm taking my car, even though the speed limit may be at 70, if there is a U-turn, I will be driving much slower. And if there is some other things, maybe no cups around, maybe I will go faster. So indeed, could a higher MAP be beneficial for kidney perfusion? Well, again, yes, maybe, but I say maybe. This is not exactly the same for all patients. When you measure what occurs to the perfusion level, you can see that some patients benefit from increasing mean arterial pressure, and some patients deteriorate their perfusion when you increase the MAP target. So obviously, you need to individualize, but this means that you need to measure. If you just go for numbers and targets, yes, maybe then take into consideration the fact that the patient may be chronically hypertensive. You may have there some improvement in the organ function at the level of the kidney in the patient who were chronically hypertensive. And this is true for many variables, including the need of renal replacement therapy, including creatinine levels, including the delta renal SOFA. If you go for the other trial, the Lamontagne trial, it was totally deceiving. The higher blood pressure level, that by the way was the lower blood pressure level of the French, was indeed no real difference in anything there. Again, I urge you to look at the data. Look at the electronic supplement, because then you discover in the serious adverse event, severe acute renal failure, yeah, it was significant, not because there was no P, but when you look at the number, yes. I mean, it was 50% higher serious adverse events for the kidney. Interesting to listen to that. Totally neglected because indeed it was E-table 8, so maybe a lot of data before to hide this kind of information. So also if you look at some other way to look at it, and of course this is just, of course, an observational data up to now. They are dealing with interventional data soon. You can see that indeed also the time spent with mean perfusion deficit compared to your previous blood pressure is also associated with the occurrence of severe acute kidney injury. So maybe not a mild one. So everything depends the way you will investigate the severity of the kidney dysfunction. And so, of course, we can also discuss the microcirculatory level. And here again, very frustrating, no rough effect. But if you look at individual patients' data, yes, some patients benefit from a higher blood pressure level, some patients are deteriorated. The sole way to deal with this is probably to measure, which is not always the case. We may admit, of course, in these conditions. And the same data here, some patients benefit from a high blood pressure target, 75 here, some patients no effect. So obviously, individualization is really the key feature. of course, say, I do not have access to this, so should I try to have something else? You may try to use the usual map as some people advocate. Maybe yes, of course, if you look at the statistical significance, you have a p-value that was positive. But nevertheless, looking at individual data, some patients really benefited, some patients really have no benefit or even deteriorated with a higher blood pressure. So again, individualization is really the key factor. Again, not easy because measuring the microcirculation is not always done. So can we have some other surrogates? Well, we may think at simple surrogates that all of you can measure the capillary fill time. And remember that in the Andromeda trial, it was here something which was interesting. When the patient failed to respond to the fluids, one of the things they suggested was a vasopressor test. And when it was positive, so this means that there was a response to it, they continue it with this higher blood pressure target. When it was negative, yes, they go back to the previous one. Isn't it simple to do? Yes. So what you need? Your finger and the finger of the patient, and just manipulating the drug level. So we can do it perhaps also in the other direction, but this was not tested here. But then you realize indeed that targeting a higher MAP is not very good for everybody, because indeed these are data from Paris, and when you can see here that indeed the variability is quite important, and in red you have the patient who benefited from the increase in MAP target, while the black are not really changing anything when you increase blood pressure. And also in the, from the Andromeda trial, you can see that indeed some patients had some improvement in the capillary fill time. Some patients also have a deterioration. So it's also very important not only to test the system, but to evaluate the response and not stick with a given number when obviously the patient is failing to respond to that number. And sometimes a lower blood pressure target may also be suggested. And you can see here, these patients had no major problems, but the problem was 11 patients in 120 shows, so only 10% of these patients. And you can see that many of these patients were really very mild patients, almost none were intubated. Then they can also evaluate the consciousness of these patients, a very important aspect. So to try to put everything together, we need to individualize, but this means not only individualize based on guessing what would be the good number, but also to test what will be the good number. And for that, it's probably good to have to begin with a given number, which is a safe number for many patients, and then to try to adapt based on tissue hypoperfusion or not. When perfusion will be inadequate, then of course give first things that improve the perfusion, like fluids and of course maybe inotropic agents if a contractility is impaired, and then consider only the higher MAP and return to the lower MAP if there is no major improvement. And again, looking at capillary fill time is probably good there. And then if tissue perfusion is adequate, in these conditions, you of course need to decrease the vasopressors, and you can also test it by simple indices like perhaps the capillary fill time to ensure that your patient is still good with lower blood pressure levels. So at the end, it's very important not to go for a fixed level, but to try to change it according to the patient and based on indices of tissue hypoperfusion or hypoperfusion. And in some patients, a higher MAP may be needed, and in some patients, a lower MAP may be also tolerated. And with this, I thank you for your attention.
Thank you very much, Professor De Becker. We have time, I think, for just one question. Any questions from the audience? Yes, please.
Markus Skrivvars, Helsinki, Finland. Thank you. Very nice presentation. So with the MAP targets, isn't it possible that some of the patients were normotensive? So even though you target 65 and you randomize 2,000 patients or whatever, not everybody will be hypotensive. And then spontaneously they'll have a MAP of 75. And that's the reason why we don't get this kind of separation that we see And then it's a different trial if we actually want to target the exact number 65 and then use some mean to lower it. What's your view on that?
That's a very good point, and perhaps even, I mean, when you discuss it's not hypertensive, what we also consider as a usual map is sometimes over-evaluated because these patients are mostly, under sedation, and when we sleep, our mean arterial pressure is also lower. So maybe we should also target this kind of pressure. Unfortunately, we often do not have this kind of information, but indeed, that's why I suggest to base it on numbers you can assess at the bedside, because often you do not know exactly how was a patient before, especially when these are young patients without comorbidities and you do not have a lot of information on the usual map in these conditions. But I totally agree that we should individualize, and some patients may probably even be better with even lower than 65.
Yeah. One more question, just last question, yeah.
Thank you very much. My question is that, of course, at the bedside, the most important question, how to individualize the targets. And what do you think about only knowing the anamnestic history of uncontrolled or controlled hypertension of the patients? Would it help to set the target, or it's more difficult?
I think that uncontrolled hypertension is really easy. This is quite easy to assess and to know. And then, of course, you don't know what was the usual pressure because it was not controlled, but it's probably a reason for going for higher MAP in these patients. When the patient is with controlled hypertension, then it begins to be more complicated because these have still endothelial dysfunction and maybe still require higher blood pressure, but for this it's much more complicated when you have a patient with adequate therapy before.
Thank you very much, Professor de Becker.
Thank you. So we have to move to the next presentation by Dr. Raimund Helbok from Linz, Austria, talking about how to individualize blood pressure in stroke.
Thank you very much. So that's, I'm now going to switch to a whole disease state, which is different to the previous talks. I don't have any conflicts of interest. I'm going to focus on patients with intracerebral hemorrhage and ischemic stroke, and especially in the cohort of ischemic stroke, about the worst patient population we treat with thrombectomy, and ask the question, what is the optimal blood pressure before, during, and after the intervention? So starting with intracerebral hemorrhage, there are not that many things how we can improve outcome. The one thing is to consider patients for neurosurgical interventions, and we have some positive trials, but to be realistic, it's only for 1% or maybe 5% of our patient population. But what we want to influence is hematoma expansion and edema progression, and that's where reversal of anticoagulant treatment and blood pressure plays a major role. And if we have to think about when to intervene, it's very clear, like in ischemic stroke, we have the golden hour in hemorrhagic stroke. So whenever you want to intervene, you have to intervene very, very early within the first hours. And after 6 hours, there's not going to be an effect size on that anymore. And about the volume, we can also discuss, so the intermediate volume ICH patients are mostly the ones who benefit because at a certain size, these are mostly the patients who come late to the hospital. So the rebleeding occurs very early, mostly before the patients come to the hospital, and then you reach a certain size and you don't see a rebleeding anymore. So what are the trials of blood pressure lowering? This is the INTACT trial, and this is the ATTACH-2 trial without a specific drug, with a specific drug, nicardipine. And this trial was actually only saw a trend for a better outcome, was not a positive trial, and the ATTACH-2 trial, lowering the blood pressure, learned us that if you go too low, you have severe adverse effect, renal dysfunction. And so too low is not good, and it was already predefined that these patient data were analyzed together, and it seemed that a certain reduction in a certain time to a certain target means that there's going to be a sweet spot, which is actually the target we should reach in intracerebral hemorrhage patient population, has a benefit on outcome and has a benefit on hematoma expansion. So what means too low? And we don't have good data on that. And this is from the quality of the data. It's not retrospective observational data. But the interesting part is that the outcome was either renal adverse event or brain ischemia, so new infarction within 7 days. And what these patients actually had, they had lower systolic blood pressure levels below 140 quite often compared to those who didn't have that. So it seems that there is a kind of a lower level of blood pressure we should target. We should not go below in the patient population of intracerebral hemorrhage patients. So what about large trials? So there was no clear answer about the outcome benefit of lowering blood pressure. And this is the INTACT 3 trial, which randomized patients to a bundle of care. That's very important. So it's not only blood pressure lowering, it's also reversal of anticoagulation, normothermia, normoglycemia. The patients were randomized, and 6 months outcome was evaluated by the modified ranking scale. And the interesting part is that compared to the control group, there was not much done about the glucose level, not much done about the temperature, but there was some intervened concerning the systolic blood pressure. And the effect size, if I can the effect size was actually not that high. Only the blood pressure of below 140 milliliters of mercury was reached within 2 hours compared to 4 hours. So it seems that time actually matters, because this is one of the positive trials in terms of outcomes, with a significant reduction of mortality in that patient population. So it seems that the bundle works, but the major effect is actually blood pressure control. But we also have to say that this was only this study was done in Limerick, so it's important to replicate that study in our area, and only 1% were on anticoagulant treatment. So what's the recommendation now? The recommendation is it's very important for the ATTACH trial and the INTACT 2 trial, small size hematoma were included. So for small size hematoma, we have the recommendation to go to a sweet spot of a certain blood pressure quite rapidly as soon as you can reach that. But don't go below 130 milliliters of mercury. What about that intermediate group, which are quite a lot of patients with intermediate or large size hematoma? We don't have an answer. We only published one study. This is observational. This is a post hoc analysis. And what we saw, if we go to the target of 130 to 150, we increase the level of hypoxic injury in the brain. So maybe for larger size hematomas, we need a different range. We might have to accept a higher range of blood pressure in that patient population, but we don't have clear data from randomized controlled trials. So what's the evidence in stroke patients? And you know, stroke is quite more often, ischemic stroke is quite more often than hemorrhagic stroke. And obviously we have to think about stroke happens already at the scene, and blood pressure intervention is very easy. And we know that if we go to the scene and we see the patient very early with these STEMO devices, there's a huge benefit on outcome. This is now shown in many trials and also in this meta-analysis. So can we go to the patient home? And this is a Chinese study who randomized patients based on the FAST score, so with a neurologic deficit. So there was the estimation of a severe neurological focal deficit, could be ischemic stroke, could be hemorrhagic stroke. And as it was done in China, you see that the hemorrhage patients is 46%, so this is not what we would accept in our patient population. You see that there is a clear separation in blood pressure, so lowering the blood pressure in the intervention group compared to the control group, and there was no benefit on outcome. But if we look at the subpopulations, and as I said, there were 40% intracerebral hemorrhage patients, and the rest ischemic stroke patients, there was a clear signal of a positive effect in hemorrhagic stroke patients compared to ischemic stroke patients. And in ischemic stroke patients, you see that if you lower blood pressure, you actually worsen outcome. So very important. If we can translate this information to the scene and have a directive to differentiate between intracerebral hemorrhage and ischemic stroke, which we don't have as biomarkers, point-of-care biomarkers now, but that's going to be the future, then there could be a beneficial effect, especially already at the scene for hemorrhagic stroke patients, but not for ischemic stroke patients. And this was also the conclusion, that we harm patients with ischemic stroke if we lower blood pressure. So what's the story about ischemic stroke patients? And the patient population you are confronted most with might be the patients with thrombectomy. And we enlarge the patient population. What for us as neurologists and for the radiologists is very important to see the collateral score, because there are certain patients who have a high collateral, high level of collaterals. This really influences also what we do and how we manage our patients. And then we know blood pressure is very important before reperfusion and after reperfusion. And so I said already, if we lower the blood pressure too low, it's a bad sign for outcome. So this is a study, this is a meta-analysis of individual data of all randomized controlled trials of the patient undergoing thrombectomy. And interestingly, there was an inflection point at 140, and you see an association with higher blood pressure levels with a higher mortality. And that was not only mortality, so that was a decreased chance of getting a good survival. It was also imaging outcomes and safety outcomes were worse. There was no difference between thrombectomy and non-thrombectomized patients. And we consider that the higher blood pressure at the beginning is more a signal for a worse clinical presentation, a worse outcome, because we have to think about lowering blood pressure at the beginning, but not going too low. But it clearly seems we don't have a clear randomized controlled trial showing the optimal level before you go for thrombectomy. So what about during the thrombectomy? And that's very important because we talk about conscious sedation versus also intubation during thrombectomy. And there's a clear signal from all the trials which show that the decrease in blood pressure is associated with worse outcome. So if we go through lower than a certain level, or if you decrease mean arterial pressure, and that's what we do if we intubate our patients, likely in more patients, that's going to happen and is associated with worse outcome. And this is a more recent study which showed that even these small reduction in blood pressure matter, because if you sum up the area under the curve of these reductions, you see that the lower the blood pressure area under the curve is, the higher the risk of secondary infarct growth, as defined as exponential infarct growth in this patient population. So can we have an individualized treatment? And we've heard that in the talk before. Can we specify, let's say the patient has a mean arterial pressure of 80, and then just stick to that level over the treatment period? And there are two studies which showed that whether the entry of that mean arterial pressure is the target that should be stabilized during thrombectomy. And these two studies had either the mean arterial pressure target or the systolic blood pressure target. And there was no difference in outcome. But what we also realized that the feasibility for that short time of intubation is actually not there. So it was very difficult to stabilize that patient to a certain blood pressure. So we don't have a clear answer on individualizing the blood pressure targets during mechanical thrombectomy. So what about after thrombectomy? And that's also obvious and an important question, because we know that if the blood pressure is too high, we have the fear of secondary intracerebral hemorrhage after ischemic stroke. And that's why many trials were performed in questioning whether a lower blood pressure target could actually reduce the incidence of intracerebral hemorrhage. This is a French trial, no reduction in intracerebral hemorrhage. This is the US trial, blood pressure targets below 140, 160, no difference in infarct size and outcome. And then the optimal blood pressure target, which was published recently in JAMA, showed that actually lowering the blood pressure below 140 after thrombectomy in the ICU, obviously, is associated with worse outcome. And that's quite important. And that study actually also influenced all meta-analysis now that we can say that lowering the blood pressure decreases the likelihood of good outcome, increases, but not significantly, increases the trend towards higher mortality. And about intracerebral hemorrhage, there is not a clear sign for that. So last, I would like to touch on the ICU, and obviously if we touch on the ICU, we have to talk about cerebral autoregulation, and that's very difficult to assess. But one information I want to end with is the variability of blood pressure. And we have clear signals that in critical care patient population, this now also includes SIH patients, a higher variability of the signal of blood pressure is clearly associated with worse outcome. So to sum up, intracerebral hemorrhage, I think we can do something with manipulating blood pressure. We should go to a target around 140 very rapidly. Don't go too low. We don't have the information on large-sized hematomas. For ischemic stroke in the pre-hospital area, we know that for thrombolysis you have to go below 185. In the other patient population, likely below 200, but stay above 150. During thrombectomy, prevent hypotension. We don't have a better information on that. And we have some studies who suggest, according to the protocol, 140 to 160 could be a good range, but we don't have that information from randomized controlled trials. And after recanalization, blood pressure below should not be achieved. Systolic blood pressure below 140 millimeters of mercury. Prevent hypotension. I didn't discuss about that the reperfusion rate, or that there are some patients where the vessel is not totally reperfused. And there are some signals from some studies who suggest that especially if we don't have opened up the vessel, a higher target may be the potential target, but for complete reperfusion we go between 150 and 160. And having said that, thank you very much for your attention.
Thank you. We can take one or two more questions.
Hello, Przemysław Rupert from Poland. Do you see a place for transcranial Doppler in managing this patient in ICU?
Absolutely. So I think transcranial Doppler is very informative to see that the vessel is open. I'm thinking you're talking about ischemic stroke patients. So that's the first information. Then we know that after thrombectomy we have hyperperfusion state. So that's also very important to record, because if you have the cerebral hyperperfusion, you should not go too high. So target a level which is around maybe 150, 160 systolic blood pressure, but never go over 180 or 200. So I think there is a value. And then if you're sophisticated enough, if you can measure autoregulation, that would obviously be of a beneficial support. So are there studies? No. Is there a clinical recommendation to use that? I think it's worth doing that.
One more question. Yeah.
Anil Gulati from US. Regarding fluctuations or variations, is there, I think what you showed, that may be quite a dramatic effect. Is there any range which is important, or your opinion on that?
So you're talking about the variations in terms of the variability of blood pressure afterwards? Yes. In the ICU? Unfortunately not. And I think that variation or variability occurs also depending on the disease severity and disease state. How can we actually influence that? That's a very difficult question to answer, because we have so many other medications which manipulate blood pressure in the ICU. But I think as we have seen in the intracerebral hemorrhage patient population, if you have a target, if you have a protocol saying that this is the optimal range for a certain patient population, you already decrease the variability. If you don't have a protocol, then you have these outranges above 200 and also below. Is there an optimal range? Yes, as I proposed the range, but how to decrease the variability, that's a very, very difficult question in daily practice, how to translate it nowadays.
Any other questions?
Just a question about measurement of intracerebral pressure. Is there a place for this or not, to individualize sometimes?
Sure. There we touch on intracranial monitoring and additional monitoring. And actually, if we put an ICP probe in, then we target cerebral perfusion pressure. And then everything with autoregulation comes up, and which is very difficult to translate into clinical practice. Most of our data, also cerebral perfusion pressure recommendation, come from TBI. And we translate that to that patient population. Is that correct? To my mind, not really. If you wanna properly monitor these patients, you need at least an additional monitoring system, like say an oxygen monitor, and then you really know whether enough oxygen is actually translated to that manipulated blood pressure. But there is a role in ischemic stroke with hemicranectomy. It's very difficult to say because you don't measure the accurate ICP because it's an open skull. You don't have the closed skull anymore. So there's a lot of question whether you can actually calculate CPP in these patient population. But in general, I would say if there's an indication for an ICP monitoring, you are more able to individualize based on these measures.
Right. Any more questions? Okay, we'll move to the next presentation. Thank you very much. Our next speaker is Professor Markus Skrifvars from Helsinki University Hospital in Finland, and he is going to be talking about individualizing blood pressure in patients post cardiac arrest.
Thank you so much for the introduction and the opportunity to discuss here with you blood pressure targets after cardiac arrest. Conflict of interest, not relevant to this talk, no commercial conflict of interest. And of course, you are all aware of the concept of primary injury, so in a patient with cardiac arrest receiving CPR, because of lack of blood flow to the brain, they will get hypoxic ischemic encephalopathy. And then on the right, the patient will end up in the intensive care unit. And of course, it seems very nice for us as intensivists to think that perhaps we can influence the brain injury in some way by, for example, changing our blood pressure targets. And of course, it's very much based on this, mentioned already by the previous speakers, the autoregulation curve. And as you all know, if autoregulation is intact, it doesn't matter what the pressure is, the cerebral blood flow will remain the same over quite a wide range of pressures related to the autoregulation of the cerebral vessels. And then the question is, if we just put one number for all our cardiac arrest patients, should it be a standard number of MAP higher than 65, or should we target higher? And there are 4 randomized controls trials looking at this, so we did a systematic review about this, and with 4 studies, little more than 1,000 patients, whether you target a low MAP of 60 to 65 or a high MAP of around 80, doesn't seem to make much difference. So overall, nothing clearly there. But of course, the question or the topic of this session is individualization. Could there be some patient within this group that would actually benefit from a higher MAP? And I'll try to shed some light on that. Well, of course, if the autoregulation curve is deranged, if it becomes completely linear, so a small change in pressure will directly influence the cerebral blood flow, that could be problematic. Or if the curve is right-shifted, then it would mean that we should target slightly higher pressures so that we would not end up on this steep end of the curve. And then the question is, can we somehow determine this in our cardiac arrest patients? And probably the only way really to do this in the cardiac arrest patient is the use of near-infrared spectroscopy. There are, of course, the invasive catheters, but because patients have received anticoagulants, Plavix, aspirin, what have you, then invasive catheters are slightly problematic. But near-infrared spectroscopy, which will give you a number about the mix of the venous and the arterial blood and the saturation, oxygen saturation of that blood below the skull. And if you then look at correlations between this NIRS value, the RSO2 value, and the MAP value, and look at changes in the NIRS value and changes in the MAP value, you may get some view of whether the cerebral autoregulation is intact or not. And this is what we did in a study conducted in the Finnish HEMS, so the Helicopter Emergency Medical Service Unit with a physician. They cannulated invasively, put in arterial lines in patients received after cardiac arrest, or they actually put them in already during cardiac arrest. But in the ones with ROSC, we were able to monitor invasively the arterial pressures and also measured near-infrared spectroscopy values during the first hour when the patient was transported to the hospital. And this is what we found. So in this patient, in blue are the RSO2 values, and in red are the MAP. And as you can see, even though there's a great increase in MAP, doesn't happen much to the RSO2 value. So these are not associated so much with each other. So if you just look at these curves, just quickly, you would think, okay, this patient has an intact autoregulation, and it doesn't matter so much what happens to the blood pressure. Then again, this patient, same 1 hour after transport to the hospital, you can see that they go completely together, these two curves, or these three curves. So a change in MAP will right away influence the RSO2 value. So in this patient, the autoregulation is likely to be disturbed. Then the question is, we can of course also use this in the ICU to look at changes in the RSO2 from changes in MAP. And Alleud, a cardiologist from Belgium, already did this in 2015. They looked at a lot of factors in 51 patients and found that in about 35% of patients, the autoregulation was disturbed. And they looked at tons of things. Can we somehow clinically predict that this patient has disturbed autoregulation? And what they found that resuscitation factors, delay to return of spontaneous circulation or rhythm or age or other hemodynamic variables, lactate, carbon dioxide, oxygen, didn't really make much difference. The only thing that was associated with the presence of disturbed autoregulation was the presence of chronic hypertension. So then, is there any evidence that if the patient has a history of chronic hypertension, we should not be satisfied with the MAP number of 65, that we should target something higher? And probably the best evidence for this is from the Box trial, a great Danish trial, blinded groups, blinded MAP groups, where they included about 800 patients with a cardiac cause of the cardiac arrest and randomized to a MAP target of 63 or 78. And as you may know, no difference overall in outcome. But then looking at subgroups, looking at the group of hypertension, nothing there either. So no signal that a higher MAP would benefit the patients with chronic hypertension. Then what about the other group, the patient group that has cerebral edema, that has the worst kind of cardiac arrest, the ones with drug overdoses, hypoxic cardiac arrest, suffocation, hangings, who quickly develop CT scans looking like that. Of course, in this group, as you know, cerebral perfusion pressure is related to MAP and the ICP. And with these kinds of scans, you have an elevated ICP. Could it then make sense to target a higher MAP? This study looked at this retrospective study, Jonathan Elmer from Pittsburgh, about 800 patients, and they tried to predict the presence of cerebral edema on the CT scan looking at these factors. And what they showed that the younger patients were more likely to develop cerebral edema, non-shockable cardiac arrest, more cerebral edema, prolonged cardiac arrest, more cerebral edema, more unwitnessed arrest, and of course the patients that were more comatose. However, the big problem, of course, was this, that the presence of cerebral edema, the outcome was really poor, with only 2% surviving. So, of course, is this very poor outcome, is this amenable to an intervention involving targeted MAP care, is going to be very difficult just because of this very poor outcome of these patients. So I think the best evidence now, I don't think we have evidence to individualize. I think the best evidence is to target a pressure of 60 to 65. If the lactate is decreasing, if the urinary output is adequate, then we are happy. The STEP care trial, a factorial trial, including 3 different arms, all types of cardiac arrest, also the hypoxic cardiac arrest, the drownings, the suffocations, the hangings. is underway at the moment. And we have a group looking at 65 or 85, a MAP. We're at more than 1,400 patients. We're likely to finish in about 1 year, so perhaps we'll have some more results on this in 2027. Finally, some conclusions. Of course, we can titrate MAP. We can give more noradrenaline. We can achieve higher MAPs. Probably the groups where there could be some pathophysiological reasoning that this is a good idea would be patients with chronic hypertension, and also the ones with deranged autoregulation and cerebral edema. But the outcome of these patients is so poor, so it makes it very challenging to do something about that. And in the meantime, until we have more evidence, I suggest sticking to the MAP higher than 60 to 65. And with that, I thank you for your attention.
Thank you very much. The floor is now open to questions. Yes, please.
Shall I put mine? A great presentation, and it's nice, I think, to have the spreads of the Leuven. I have spent a few years together. One question about the NIRS. So we are also investigating the cerebral autoregulation. We investigated to a MAP of 35 in elective surgery. It turns out there is no lower limit, a fixed one. It is very individualized, and even below we thought the lower limit, it is still able, the brain, to react on it. What we do is we use transcranial Doppler and NIRS, because only the NIRS we have the frontal, and so the big question is NIRS really the tool we need, or should we go more advanced? Because I think we all know cases with beautiful NIRS, but in the end, posterior, there is a huge problem.
I completely agree. It's a great question. And the two graphs I showed you were the extreme samples, the easy samples. Most of them did not look like that. And we've also studied NIRS in the ICU, and in cardiac arrest patients didn't really give much. So it's definitely not optimal, and we need something else. The problem is that something that would also work in the ambulance, that's non-invasive. I'm not sure if we're ever going to have that tool, but I completely agree with your point that it's definitely not ideal.
Yeah, just one last question, yeah.
I do have some concerns about recommending NIRS, because we know it's a contaminated signal what we have, and also from animal studies we know that once we give vasopressors, the signal is very difficult to interpret and does not reflect cerebral oxygenation. Can you briefly comment on that?
So that's a great point, and to make perfectly clear, I do not recommend NIRS as clinical practice. It's a research tool at the moment. The graphs we showed were the nice ones. I don't think, and the problem is, of course, what do we do with this number? How does it change practice? If we turn up the oxygen to 100%, the NIRS value will go up. There's no question about it. Much more than changing MAP. But is that a good thing? Nobody knows. So do not use NIRS, is my suggestion, in cardiac arrest patients, unless you're doing a clinical trial.
Thank you very much.
We have to move to the next presentation by Geert Meyfroidt from Leuven, Belgium, about traumatic brain injury.
Thank you. Thank you for the speakers to invite me, and it's good to see that there's such a large audience here about individualization of blood pressure. It's all a matter of balance, right, in life. So you don't want to give too much, you don't want to give too little. And in traumatic brain injury, this is sort of an decennia-old discussion that goes on between two protocols, a cerebral perfusion pressure-based protocol, which of course can have a risk of brain hyperperfusion. On the other hand, a low CPP protocol control based on mainly controlling ICP, which of course then bears the risk of hypoperfusion. And there's actually only one trial who has ever addressed this, which is the, at least in neurocritical care, legendary Claudia Robertson trial from already 26 years ago, where they compared both approaches, where they randomized patients to a higher CPP versus were allowing CPPs to go to 50. And what they saw was that there was no difference in outcome. Both therapies had side effects, but this would not be reflected in a change in TBI-related outcomes. And so people would think about that. And so one of the hypotheses about the difference in the two protocols was that it was related to cerebrovascular autoregulation. And this is a paper by Tim Howells from Sweden. And they actually calculated whether patients were actively autoregulating or not. And it turned out to be that the low CPP approach was better if autoregulation would not work, whereas the high CPP protocol was better if it would work. And that sort of got reflected in the guidelines. Now, these guidelines are quite tight and quite abstract, I would say, because the recommendation now is to keep it between 60 and 70 and to aim for 60 or for 70, depending on the autoregulatory status. Now, I would challenge anyone in clinical practice to do that, to target 60 or 70 in one patient, as if our patient has a button where we can just set CPP, which, of course, is not the case. I don't think I need to explain cerebrovascular autoregulation, but just this graph that you see pop up here is from this paper by Niels Lassen from the 50s, where he actually grouped a number of experiments in totally different settings and discovered a lower limit of autoregulation. I think this is a sort of a study that we would not publish anymore right now because of the clear heterogeneity in the groups. And what we think now is that this plateau is definitely not as wide as Lassen proposed it, and that in particular the upper limit of autoregulation is very difficult to detect. But in many of our brain injured patients, autoregulation will be impaired, and this impairment can be that the plateau is narrows, that the plateau shifts, and within a patient this can shift throughout his course, and between patients there's large differences about that. Now, if we all think that autoregulation is so important, you would think that we have consensus about that. And in 2019, we had the ICP conference in Leuven, and we, with a group of experts, tried to find consensus. But there was actually not much consensus about how to assess autoregulation or how to implement this in clinical practice. There was consensus that it's important, and there was also consensus that a universal CPP for all patients is probably not advised because it's probably not how it works. And there's several ways, and people have already addressed this question, how can you actually assess autoregulation? Well, what you want is you want to monitor cerebral blood flow in response to a blood pressure change. And this can be a spontaneous change. You just observe what happened in the patient, or you can induce a change, and then you assess a measure of cerebral blood flow, which can be TCD, which can be invasive monitoring, which can maybe be NIRS, although I totally agree with the comments by Markus and Raimund that NIRS is maybe not the most reliable method. And the way it can work is this. So this is a patient with a contusion, with a small bone flap, where you can see that a change in blood pressure was induced here. And what happens is that the ICP goes down. What you also see is that, especially on the right side, that is that the brain hyperperfusion is now being reduced. And this is reflected on the right side by an increase in blood flow velocities measured by TCD, which shows that there's vasoconstriction in that vessel. Now, are there continuous, because this is of course labor intensive and maybe you don't want to induce this change in blood pressure in all these patients, are there ways to monitor autoregulation in a more continuous way? Well, there's indices proposed, and Markus already showed you the ICM Plus software. So this is specific research software that you can apply to your patient in clinical practice that will actually calculate the correlation between a signal of cerebral blood flow and the blood pressure. And in this case, because we think the patient is on the narrow part of his pressure volume curve, because the ICP is already a bit elevated, the change in cerebral blood flow will reflect a change in cerebral blood volume and thus a change in ICP. And then if the correlation between blood pressure and ICP is linear, it's clear that the patient doesn't autoregulate, and if this is negative or close to zero, the patient is autoregulating. And so this index is called the PRX, and actually you can plot, so the software provides you with this frame, has nice reflection of the past CPPs. And what you can also see is that the zone where the PRX, where this index of autoregulation, where the correlation between the two signals is most negative, is the lowest. You can assume that this is the zone where autoregulation is most active. And this was called the optimal CPP or CPP-op. The question is this truly the optimal CPP? We don't know. But the question is, if you would aim your CPP into that zone, would it improve outcome? Well, in retrospect, it does. So this is a study by Marcel Arias, and they looked in retrospect whether patients whose CPP was closer to this calculated value with CPP-op had better outcomes, and this was clearly the case. So we decided with 3 and then in the end 4 centers to test this in a clinical trial, which is a Cogitate trial. And the logo of the Cogitate trial tells you what we compare. So we compare a fixed CPP of 60 to 70 versus this dynamic optimal CPP based on PRX. And this trial was not powered for an outcome benefit. It was just a trial that we did to see whether it's actually feasible to do this. And this is the trend line of recommendations. So the patients were randomized. One in the control arm, you would just try to maintain CPP between 60 and 70. In the intervention arm, you would get a new target every 4 hours that you were asked to follow by using whatever measure you thought was necessary. So these are the targets every 4 hours. This is what then happened to a patient. So this is a case of a single patient. Now, what was the result of the trials? That is that in the CPP-opt arm, we had, in about 80% of the time, there was a recommendation of a CPP, and so we could steer it in that range. But it was only possible to actually keep the patient within that range in less than 50% of time. So you can ask yourself, is that a success of a trial? It shows the complexity of the intervention. You should know that the centers who participated before academic centers used to working with the software, and so were very motivated to do this. So you can assume that if these motivated centers are only able to get this target in 50% of the time, that maybe in less motivated centers it would be even more complex. ICP was the same. CPP was higher in the intervention group, and there was no difference in autoregulation between the two groups. The study was not powered for outcome, but there was a trend towards a better outcome in the intervention arm. But this, of course, can be sort of a Hawthorne effect as well, because the study obviously is not blinded. Now, ICM Plus software is very expensive. I don't think that that everybody can afford that or will be willing to work with that. But can you as well work with autoregulation? I think you can. I think what we do every day in the ICU is that we try to change things for the better, and that we then see what the result is. And the advantage in brain-injured patients, especially in TBI, is that in many settings they are invasively monitored. They have an ICP monitor, especially in a Western or European setting. Most of these patients will have that, and some of them will even have more monitoring, such as brain tissue oxygen monitor. And what you can actually do is that you if you think that blood pressure is inadequate or that you can improve things by manipulating blood pressure, is that you do that. You do a MAP challenge. You do a small change in blood pressure by, for instance, 10 millimeters of mercury with vasopressors, such that you can go back and you see what happens. And in theory, if such a MAP challenge would be positive, like here, if we would increase CPP with 10 millimeters of mercury, and autoregulation would be active, we would expect that there would be vasoconstriction, less cerebral blood volume, and the ICP would go down, and that we would improve brain perfusion. And this is also now recommended. This is a non-evidence-based guideline. This is an expert guideline, the CIBIC guidelines, but this MAP challenge is incorporated in these guidelines, and this is a way how you at the bedside can do this. If we look at the large OxyTC trial, which has studied a PBTO2-based versus a non-PBTO2-based management of TBI patients, the study was neutral, but what we did find in the patients with elevated ICP, there was a trend towards better outcome in this trial. And it was also, so you can clearly see the intervention group had on average higher CPPs in their patients, and actually increasing the CPP was one of the interventions that was proposed to improve the PBTO2. So to conclude, I think the Cogitate trial showed that we could attain a dynamic target in about 50% of time. Whether that is a proof of feasibility or not, we can debate about that. It was not powered for outcome benefit. But even while there's still uncertainties, I think by being at the bedside and looking at your neuromonitoring, you can integrate cerebrovascular autoregulation in your thinking about your patient and to see whether actually manipulating blood pressure improves the numbers that you monitor, the invasive brain monitoring numbers that you have, even while we don't have an evidence that this will improve the outcome of the patient. And with this, I would like to thank you.
We have time for just one question. Any questions from the audience?
Yes, this is a conclusion of this session. If I want to summarize, I would say that it is still difficult to individualize the blood pressure, maybe except in some situations where we have some parameters to look at. But in general, until right now, in the majority of cases, lower blood pressure, I would say, are recommended. But my profound belief is that in some years, probably we'll have more parameters to look at to more individualize our management. Thank you very much, Geert.
Thanks.